a link to ketoacidosis was suggested. These are my disclosures. So I would like to start with the quote of the famous TV producer who said, "Today's medicine has progressed so much that only rarely a man dies without medical assistance." So this is in particular true nowadays when multiple new medications with unknown side effects are introduced in type 2 diabetes. SGLT2 inhibitors are a relatively novel class of anti-diabetic medications. They reduce glucose reabsorption, leading to glucosuria and energy loss. Latest studies have shown their ability to reduce body weight and cardiovascular morbidity and mortality. And real data, however, points out some serious side effects like renal impairment, ketoacidosis, elevated fracture risk, urinary tract infection, and so on. It was suggested that SGLT2 per se do not cause hypoglycemia until they combined with the well-known hypoglycemic agents like insulin. The combination of SGLT2 with anti-hypoglycemic agents like incretin-based therapy was proposed as hypoglycemia safe. So we studied all medical records of all 136 type 2 diabetes patients in our institute who were treated with SGLT2 inhibitors for the last 2 years. Medical records of 52 patients who performed a routine CGM investigation by professional CGM of Medtronic iPro2 were separately assessed. We were surprised to recognize the Group A hypoglycemia group, which contains 9 patients with hypoglycemia, and it was subsequently compared with Group B, 43 patients without hypoglycemia. Now, every type 2 diabetes patient in our institute, starting SGLT2, receives a kit to measure beta-hydroxybutyrate in concentration in capillary blood by freestyle Optum. Our patients were instructed to check their beta-hydroxybutyrate every week in the morning before meals, and patients who experienced the beta-hydroxybutyrate elevation above 2 millimole per liter performed twice were considered experiencing ketoacidosis regardless of their clinical signs, and they were instructed to stop immediately this medication and inform their treating physicians. So when we compared the two groups of patients, namely Group A, hypoglycemia group, and Group B, non-hypoglycemia group, no differences were discovered in all of parameters like sex, age, diabetes duration, basal A1C, and kind of therapy. The only diverse parameters which were revealed to be significant were the estimated A1C and sensor-derived A1C and mean sensor glucose, which were significantly lower in the hypoglycemia group. So this data comes in accordance with a well-known statement which claims the stricter the diabetes control, the more likely the patient is to have hypoglycemia. Another 3 patients had developed ketoacidosis on SGLT2 therapy. This is the case 1, case 2, and case 3. And all of them, insulin had been stopped earlier because of a very good glucose control and absence of a necessity for further insulin therapy continuation. So we can see here that insulin was stopped in 3 cases, and probably this was the trigger. Now, when we analyzed separately all 9 patients with hypoglycemia in hypoglycemia group, we revealed that 3 patients experienced hypoglycemia on combined therapy with low doses of basal insulin, which does not come in surprise. Which does come in surprise is that remaining 6 patients without any hypoglycemic therapy like insulin, sulfonylurea, and glinides developed pretty serious hypoglycemia events, and some of them up to 7% time in range. Now, the average time in range in all of this group was 3.5, and minimal sensor glucose in average was 49.9, which is quite impressive. The upper graph, upper CGM recording, addresses the 66-year-old man who suffers from diabetes for the last 10 years and is constantly treated with linagliptin and metformin. Recently, dapagliflozin 10 milligram was added, and newly onset complaints of perspiration at nights appeared. So here we see the reason of these complaints on the CGM recording. The lower graph addresses the 71-year-old patient who was constantly treated with combination of metformin with 10 milligram only of empagliflozin. When we elevated the dose of the empagliflozin to 25 milligram, the patient started immediately complaining of the clinical signs of hypoglycemia, and this is the confirmation of this kind of complaints. So whether there is a link between hypoglycemia and ketoacidosis, we believe the answer is yes. And we believe that we are not talking about so-called euglycemic ketoacidosis, which sounds absurd, but rather about hypoglycemic, hypoinsulinemic, hypoglycemic ketoacidosis development. When we see this from the energy point and energy-based point of view. So we see that SGLT2 inhibitors, through daily leakage of hundreds of kilocalories, result in rapid disappearance of insulin resistance on hyperinsulinemia background. This results in prolonged and recurrent hypoglycemia in some patients and elevation of glucagon and insulin as a result. Now, the next very, very important stage is the glucagon store depletion. Actually, without the glucagon store depletion, the ketone body production is impossible. But when depletion occurs, then shifting of gluconeogenesis from glycogen to fat sources proceeds, and this results in ketone body production. To summarize, real-life practice discovers more frequent than previously reported rates of hypoglycemia and ketoacidosis in type 2 diabetes patients taking SGLT2. Pathophysiological link between the two conditions through development of hypoglycemic, hypoinsulinemic ketoacidosis is assumed, and more studies, of course, are needed to confirm our hypothesis. But anyhow, it's all about energy in type 2 diabetes. Thank you for your attention.
Thank you. And I have 2 questions. Are there any type 2 patients that are more prone to develop this DKA? For example, those that are consuming low-carb diets or something like this?
We strongly believe that the high-risk group is those patients suffering from type 2 diabetes, which are, first of all, very well controlled, this is the first, and lose their weight rapidly, more than it was expected. So, of course, the prolonged starvation is the very high risk for development of ketoacidosis, and this is not a case that the FDA strongly recommend discontinuation of SGLT2 in patients who prepare to prolong fasting on medical procedures and much surgeries.
And you have mentioned that you measure the ketone bodies in the blood once a week. Do you think that it's enough to measure it once a week?
Probably it's not enough, and probably the high-risk patient demand more frequent measurement, but it is the lesser of evils, I think, to measure it at least once a week, in the morning and before meals.
Okay, thank you. Any other
Thank you.
questions? Yes, please.
Can you correlate the frequency of this to body mass index in any way? Were these patients tending to be less overweight than perhaps the general population?
Yeah, I can correlate, clearly we can correlate these to the delta BMI and on the timeline. So again, if our patient lose their weight much faster than it was expected, it is a high risk, it is the higher risk to development of ketoacidosis and hypoglycemic, hypoinsulinemic ketoacidosis.
So thank you very much. And we